Welcome to Doc Discussions with Dr. Jason Edwards, brought to you by St. Luke's, St. Louis. Welcome to Doc Discussions. I'm Dr. Jason Edwards, and I'm here with Lola Brand and Dr. Kristen Fisher. Welcome.
Welcome. Thank you.
Hi.
So Lola is the head of our lung cancer screening program, and Kristen is a pulmonologist here. Kristen, can you tell us a little bit about yourself, where you're from, how you got here?
So I grew up in Alton, Illinois, and did my medical school at SIU in Springfield, Illinois, and residency in Indiana, and then came back for fellowship at Washington University, and then took the job here in 2018 after I finished, or 2017 actually, after I finished fellowship. And so I've been a pulmonologist here now for over 8 years.
Yeah, very good. And you went to medical school with Ryan Reedy and John Holson.
I sure did. All three of us were in the same class, as well as Ryan's wife.
Very good. That's a strong class. I mean, those are some great doctors. And so, are all of the SIU physicians as highly touted as you guys are?
I hope so. I think so. Obviously, they're the ones who are around here. But yeah, it was quite ironic. I feel like when I had been in practice for about a year when Dr. Reedy came, and I was like, oh, wow, we were in the same class. And then now with him doing thoracic surgery, we work pretty closely together. Yeah.
Great guy, great surgeon, as is John Holson for sure.
Yes, John's great as well.
And Lola, where are you from originally?
Waterloo, Illinois.
Okay.
Grew up on a farm, went to nursing school at Barnes Hospital School of Nursing, came here in 87 and have been here since then in multiple positions. Yeah. Nursing on the floor, case management, and now for the last several years in the lung screening program.
Okay. Now, what kind of farm was it that you grew up on?
We had pigs, cows, sheep, grain farm.
Yeah.
Trucking business.
Hampshire pigs.
Oh, they had all kinds of pigs.
Yeah. The pigs get big. They're like 800 pounds. And so, yeah, very good. Okay. And so, Lola, can you tell us a little bit about the lung cancer screening program we have here?
Okay, so the lung screening program has certain guidelines that has been set down by the United States Preventive Service Task Force. You have to be between the ages of 50 and 77 if you're a Medicare or a Medicare Advantage plan, 50 to 80 if you have a commercial plan. You have to have a current cigarette smoking history or quit smoking cigarettes within the past 15 years and have a 20-pack year history. Been seen by a physician who has documented that you are asymptomatic of any kind of lung cancer symptoms. And then we just set you up for the CAT scan. It's a very simple test. And the result letter is sent out by myself. The doctor should be calling with the test results, and we just do that on an annual basis.
Very good. And you always have a great interaction with our mutual patients, and we very much appreciate you.
Thank you.
You're a detail-oriented nurse navigator, and I think it makes a huge difference. So thanks for everything you do.
Thank you.
Kristen, what are some of the early warning signs that somebody may have a lung cancer? What do people present with?
So typically, unfortunately, which is why the lung cancer screening program is so important, that a lot of times, unfortunately, by the time somebody has symptoms, it is a little bit more advanced than what we would like to capture. But some early symptoms, and sometimes you can find it early if it's something that's maybe obstructing an airway, which the patient may be short of breath or coughing up blood. Sometimes there's chest wall pain. Not coughing. Sometimes I've found it before with patients coming in with a cough, which is why I'm pretty careful about making sure that I get imaging on appropriate patients.
Yeah, you're right. And most of these are caught at stage 3 or 4. And so that's why you've got to screen even if you have no symptoms.
Correct.
Sometimes you get lucky and a small lung cancer is next to a windpipe and there's a little bit of bleeding and you catch it before it takes off. But it's a sneaky cancer that can really grow without symptoms. Smoking's the most common cause for lung cancer, and it's the vast majority of patients. What are some other things, if you're not a smoker, that could lead to a lung cancer?
So exposures, a lot of patients with prior asbestos exposure, radon exposure, other chemical exposures and things like that can place patients exposure to carcinogens, can place patients at risk for cancer. Age in itself is a risk factor. So, always following pulmonary nodules that are sometimes incidentally found even in patients who are non-smokers are important in following appropriate guidelines for follow-up. There is an increased risk after the age of 65, specifically family history for lung cancer.
Do you think that's genetic, or do you think it's secondhand smoke, or a little bit of both?
Probably a little bit of both. I definitely think there are a subset of patients that probably have some genetic predisposition, because some of those patients I've seen and I'm sure you've seen them as well, that have had kind of multiple adenocarcinomas, in which case, and not even be, that advanced in age, or, you can't really identify it. Although it's sometimes hard to pin down exposures. I find that it's really difficult sometimes because people don't always remember, certain exposures that they've had in their lifetime.
Yeah, for sure. And radon gas is, I think, a bigger deal in Missouri than it is in most places because of the limestone. Is that right?
I believe so, yes.
Yeah. And so you can buy a radon gas kit and test your house. It's relatively cheap, or have an expert do it. But I think usually when you buy a house, it's mandatory.
That is, they'll give you a measurement when you buy a house.
Yeah.
And
especially if you have a basement, right?
Exactly. And it has to be below a certain level. Otherwise, I think there's issues with selling it.
Yeah, which is very good. You mentioned lung nodules. Why do so many people in St. Louis have lung nodules?
It has to do with where we live geographically. There's a fungus in the soil here called histoplasma, and it tends to cause a lot of pulmonary nodules because people will breathe it in, your body kills it, leaves behind, evidence of it being there previously. But the problem is although it's very common to find, you can't tell a difference as a physician when you look at a scan between one of those nodules typically and one that could be an early lung cancer. So although the vast majority of nodules that we find incidentally end up being benign, you have to appropriately follow them in order to ensure that this is not an early lung cancer, because obviously, as we've discussed earlier, by the time somebody's symptomatic, it may be more advanced. And therefore, finding it at an early stage in which it can be potentially cured is very important.
Yeah, for sure. I used to live in Kentucky, and it's on the Ohio River Valley, and they have the same thing on the Mississippi and Ohio River Valley in the Missouri. And so there's a lot of lung nodules out there. So, most of the time when you have a lung nodule, it's not cancer, but you need the tincture of time to kind of discriminate. Histoplasmosis nodule won't grow over time typically, whereas a lung cancer will.
Yeah. And it depends, valley fever for people that live out west, there's other endemic fungi throughout the U.S., but there's specific areas such as here where it tends to be a little bit more concentrated.
Now, valley fever, I'm totally unaware of. What is that?
So that is coccidiomycosis, which is another type of endemic fungus, and it's typically in Arizona, California. And so sometimes when I have patients that may live part of the year in Arizona and part of the year here, we'll find them. It tends to make people a little sicker. So some people actually have, a fever and cough with it, but it will leave behind these nodules, or even sometimes even bigger than a nodule, that makes, when you first see their CT scans, you might think that somebody has lung cancer, but it ends up just being a prior fungal infection.
Huh. And usually from the histoplasma, people don't really feel sick.
No, it rarely. Occasionally, somebody can have active infection. That's usually in somebody who has something wrong with their immune system, that they're compromised in some way. Sometimes it can still happen in healthy individuals, but most of the time it doesn't need to be treated, even in those cases. Most people don't even know they have it.
Yeah, that's been my experience as well. So we talk about these nodules and the low dose screening for the high risk individuals. What's the difference between catching one of these nodules early versus, catching the tumor when you have a clinical symptom?
And there's a big difference in terms of prognosis, and you would be able to answer this better than I would, but if a cancer can be found in an early stage, such as a stage 1, it can either be removed or radiated, depending on what is the best choice for that particular patient. And the patients tend to do great, versus if it's more advanced, then it's going to involve, potentially chemotherapy or immunotherapy. And it's a lot more for the patient. And, it's a lot more involved and a greater chance of recurrence afterwards than if it's caught early and dealt with whenever it's a small nodule.
Yeah, I think, out of all the cancers we screen for, which is breast, prostate, colon, and lung, and cervical cancer, you have one of the biggest deltas between, catching it early versus late, just because patients have such a rough time when it's caught in stage 3 or 4. With the new immunotherapies and the targeted therapies that the medical oncologists use, cure rates have improved for stage 3 and 4 patients, but it's improved from if you look at the whole lot of them, from 20% to 30%. And so it's still not great odds. So you see patients before I do typically.
I typically do.
And, you're the one a lot of times that will even diagnose the cancer. How do you diagnose the cancer? What procedures do you do?
Yeah, so I do a procedure called a bronchoscopy, which is a scope of the lungs. And there's different ways of doing biopsies in order to using different tools while I'm doing that in order to try to find the nodule. But there's multiple ways of doing a biopsy. I typically think of, when I explain this to patients, there's really 3 different ways you can get at trying to determine what exactly a spot is. So this would be a spot that may be growing. It may be a spot that's large enough that I'm concerned about it to begin with. And I always tell people you can biopsy it from the inside out or outside in. And I do it from the inside out, which means that the patient is put under anesthesia and I put a scope into their lungs, similar to how somebody would get a colonoscopy if they were or an endoscopy, but it's in the lungs, not into the GI tract. And then using different technology, sometimes there is something that we do called navigational bronchoscopy, where you can create a 3D map. There's robots now, which we may be getting soon here, where you can try to get at the spot and get a diagnosis that way.
So you kind of go through all the windpipes.
Mm-hmm. You create, it's like a map. So it's kind of like a video game sort of, where you follow that. It will, show a target on a screen that looks like, I always say the green ball, and you can navigate out to it and try to get to it. And then if there's any concern for lymph node involvement, there's ultrasounds that we can use through a scope. We're basically taking very tiny biopsies. The other way is what I mentioned, which was from the outside in, which is the radiologist will do this called a CT guided biopsy, where a patient will be in a CT scanner. And this one, they don't have to be put under anesthesia for, and they can stick a very tiny, numb up the patient and stick a very tiny needle in through the chest wall and get a diagnosis that way. And then the third way is obviously surgically. So just depending on the situation, depends on which way we may go about offering a biopsy. So typically that is what happens. Typically I'll be referred a patient at the time in which a nodule, either I find the nodule whenever I'm doing screening or working them up for something else, or the primary care doctor we'll send it. Lola's very good about identifying patients on, if somebody has an incidental scan in the emergency room, and making sure those patients get in to see somebody, to do the appropriate workup. And then after I figure out what the diagnosis is, then I refer them to the next step.
Yeah. So a couple technical questions.
Mm-hmm.
So the lung is in a way kind of like a balloon, and
Mm-hmm.
when you stick a needle in it, sometimes that balloon can deflate.
Correct.
And we call that a pneumothorax. Correct? Is that the right term?
That is the correct term. Yes.
And so is the rate of a pneumothorax lower with a bronchoscopy than it is with a CT guided biopsy?
Yes.
Okay. Yeah, that's because that's pretty rare to have it from a bronchoscopy.
It is pretty rare. I think it's cited in the literature. It's somewhere 1% to 2%. The way I think about it, the differences between the two is that a CT guided biopsy, though, has a little bit higher yield, meaning that there's a little, but it just depends on the nodule too. It really depends on where it's at. But the the chance of getting the diagnosis, like say it's cancer, and getting back that it is cancer is a little bit higher yield with that versus a bronchoscopy. So all of this has to be taken with the lens of the person doing it if you think you really got adequate sampling or not when you did it. But bronchoscopy technology is improving, and that's why I had mentioned there's some newer techniques out there, and so we all adapt with the times and try to constantly try to seek the latest technology in order to try to get a better biopsy.
Okay, so now I'm going to ask you a question that's a little bit of a curveball, okay?
Yeah.
So they're talking about these AI robots doing surgery, and it's kind of all the rave. Do you think that will come to reality? I mean, it's kind of hard to bet against Elon Musk, right? You kind of feel like a fool, but they're talking about these robots being able to perform surgeries potentially better than humans. What do you think about that?
I don't know.
That's a great, honest answer.
I don't know. I think that it has a way to go before we would ever get to that point. I think that there's great ways of using that type of technology to assist the human and being able to do what needs to be done. So I think that the reality of what would probably happen, let's say for a bronchoscopy and trying to help me better get a better sample, get it better, would be using AI to help direct things, but still being controlled by ultimately a human having to make real life decisions at the time. Because I think we all know AI gets a little wonky. And I just have to say from my experience using it I use it for documentation purposes. It does some strange things sometimes. So I do not think that it is at the point of which that we're anywhere close to that. But I do see AI coming into effect is assisting us be able to do our jobs better, not replacing us doing it.
So like the co-pilot, right?
Yeah, the co-pilot.
In the plane.
Like it can say, come up with a plan, and I can look at it and be like, okay, yeah, that makes sense.
Yeah.
And use it to help me get there. But at the end of the day, you still have to have somebody that's able to make sure it's not going to go into crazy computer land and do something strange.
Because they can hallucinate, I think is the term they use, where they just kind of go off res and start doing some weird stuff.
Occasionally I'll have some stuff show up in notes that I'm like, what's this talking about?
Yeah. Well, thanks for kind of giving your input into this. And so a last question. When patients are diagnosed with a cancer, what advice do you give them about how to psychologically deal with it? Because I think in many ways, the first 2 weeks are kind of the worst.
It is. I think the uncertainty is really hard. And I think that it's a little bit different on the level in which, those of us like Lola and I on kind of the front end and dealing with this kind of stuff, what they're experiencing, by the time they get to the oncologist, they kind of have, most of the time, they've had a chance to kind of wrap their head around the fact that the patient has cancer and kind of really looking forward to like getting the answer, like what's going to happen next. But I have at the stage where somebody comes in and they're, I'm like, well, I see this spot and I'm worried about it, but we don't know what it is. And that part is very difficult to handle. I think psychologically, some people do really well with it, and some people it's very nerve-wracking. And the whole process of sometimes us following nodules and saying like, well, we don't, it looks okay right now, we're going to wait a few more months. Like sometimes that waiting that few months is really hard. And so what I always tell people is like, let's just take this step by step. Like there's only so much we can control. I try to gauge when I'm talking to somebody how much information they want to know. Some people want to know the minute that spot's found, like what's the worst case scenario. And if they want me to take them down the rabbit hole, I'll go down that way. And I'll say, well, worst case scenario, this is probably, as long as we get, this back and it doesn't look like it's spread anywhere, this is probably a stage 1. And this is kind of what that looks like. We might be talking about surgery, or if it's a patient that I don't think is a surgical candidate, we might, or maybe they don't want to have surgery. We talk about radiation, and I don't give them a ton of information about that because I feel like, you do a great job, for example, of going through radiation with the patients, but I give them an idea of what that looks like. And so for some people, they want to know that information. Some people don't want to know that information. So I think you just have to try to gauge like how much they want to know, but I'll answer as many questions as somebody has if that helps them kind of process the situation. Sometimes knowing like, well, what are we going to do if it is this? And I'll be like, look, we're not going to go down this way. We don't even know if this might be something that's going to go away on the next scan. But if it does, this is what you're looking at. And I think that sometimes helps people be able to know like what they're facing.
And I think that's a sign of a great doctor that knows their patients and kind of knows, like, I know them, I know their personality, I know this is kind of how much they can take right now, and it's not going to be healthy for them to kind of go down this road. And, I think the serenity prayer is really great for a lot of things in life. And it's that a lot of things are out of your control, and you've got to somehow find peace in life knowing that you can kind of only control a couple things, and you're better off focusing on that. The mind, it most of the time works against you, and it'll just take off, and you got to try to keep it reined in. And I think that's great advice, to try to stay busy, to maybe go for a walk, kind of wear your body out so your mind's not working so hard against you. But it's for people out there who just get a cancer diagnosis. I mean, it's the first couple of weeks are just the toughest, and you've got to not let your mind break you down. But it's tough. I mean, even knowing that, it's still not easy.
It's tough. And, it's hard because although we see people go through this, I don't think anybody really understands what it's like unless they've been through it. And so as empathetic as I try to be, I do recognize that it's tough.
Yeah.
It's tough for people. And,
it makes it all the more important to have people on the front end of it that are so kind and empathetic like you two. And so I thank you both, Lola Brand and Dr. Kristen Fisher, for all the great work you do for our patients.
I would just like to add that the lung screenings are a free exam under most patients' insurance, in that it's a preventive exam. So there's no cost to patients to get that on an annual basis. If they have to come back for a CAT scan because they did find a nodule, those costs will go under their diagnostic benefits. But I think people need to be aware that this is something their insurance companies do cover fully, and hopefully that will lure more people into coming in and getting the lung screenings.
Lola, is there a way that they could contact you or your office or the lung cancer screening program?
Yep. My phone number is 314-205-6550. Please call, leave me a message. I will work out on getting orders from your physicians, explaining the procedure, and getting you set up.
Oh, well, thanks so much for being an advocate for so many of our patients, Lola.
Thank you.
Yeah, thank you,
Thank
Lola.
you.
Lola,
Thank you.
Lola always makes sure we're on our toes.
Yeah.
I
Thank you.
appreciate that.
Well,
She does a
and
great
you guys
job.
do a good job, too.
Yeah,
Really well.
yeah, I think we got a great team from top to bottom, and I'm thankful for everybody. All right, well, that's it for Doc Discussions. Thanks for listening.
Join us next time for Doc Discussions with Dr. Jason Edwards. It's medicine for your body, mind, and spirit.